Hello and welcome to another episode of Understanding My Body Through My Mind. In today's show, we have the incredible Dr. Anna David, a consultant and professor in obstetrics and maternal-fetal medicine. She provides hands-on care at UCLH's fetal medicine unit, performing ultrasound, counseling, and procedures like amniocentesis. She founded the preterm birth clinic for women at risk of early delivery or baby loss and is the director of the Institute of Women's Health at UCL. She leads groundbreaking research into new therapies for pregnancy complications like fetal growth restrictions and preterm birth. She also developed MFAET, a globally adopted system improving the safety of clinical trials in pregnancy. We hope you enjoyed the show.
Listening at the moment is because I saw you a couple of weeks ago at an event for women's health on International Women's Day, and I was absolutely mind blown with the information that you was giving us about what is currently available for maternal fetal medicine, and I was just like, what? The general public must know about this. So I just wanted to thank you again for taking time out of your very busy schedule to come and see us, and welcome.
Well, thank you very much. Thank you for having me. It was a really exciting event. It was great to see so many people from all walks of life, patients, public, general punters coming along wanting to find out about it. And it was a really great event. Thank you very much for inviting me. I'm always happy to wax lyrical about women's health, the importance of reproductive health, the importance of life course health to our future families, our population, our generation. So really, really happy to be here and tell you about what's coming. It's exciting times ahead. We've got a lot of technology which is going to be applied to fetal medicine and maternity, and it's a really exciting time.
Amazing. So I have this habit of just diving straight in and getting into the nitty-gritty of things. So I'm going to ask you the first question, which is, what are the biggest challenges in maternal fetal medicine that we're facing in today's world?
I think the biggest challenges are that we can do a lot, but we find it very difficult to assess what's going on with the baby before birth. So I think that the difficulty we have is that the womb is a bit of a black box. So we probably know more about our brains than we know about the uterus, the fetus, and the placenta before birth, because it's actually a lot more easier to get information about brains. We can do MRI, we can do CT scans, you can do all this kind of clever stuff, but we've really only started delving into pregnancy and the uterus and the fetus, the baby before birth, and the placenta and how it all works. And that's because it's actually really difficult to do, because if you try and do some kind of intervention, if you try and measure something, or you perhaps put a needle in to measure something in the amniotic fluid, you might actually cause that woman to go into labour. And so that's why it's really challenging. So we have to sort of use non-invasive methods. We have to use new technologies, perhaps new imaging methods, to tell us about what's happening to the baby before birth. We are improving our knowledge. There's particular types of technologies that I can talk about, which are telling us a bit more about how the fetus is and how the placenta is functioning. So I'm an obstetrician, maternal fetal medicine specialist. I do about 60% research and about 40% clinical work. And I focus on women who have high risk pregnancies. So women who perhaps have had a previous preterm birth, or women who've been diagnosed with a small baby. So a baby that's growth restricted, fetal growth restriction, that's not growing in the womb. And it's my job to try to improve their outcome. But a lot of the time, I have to rely on tools that have been around a long time, like ultrasound, for example. And ultrasound can tell you an awful lot about how the baby's doing. So it can tell us about the baby's size, it can tell us about the baby's movements, it can tell us about the baby's structures, and it can also tell us lots about blood flow from the baby to the placenta, but it doesn't actually tell us how that baby is. So we can't directly measure oxygen in the fetus, and we can't directly measure oxygen in the placenta, and we can't directly measure how that placenta is functioning. So that's one of the big problems. And although we can assess fetal size and we can plot out what normal babies should be growing at, the rate of a normal growing baby, it's actually quite difficult to predict if that's the size the baby should be or whether that baby isn't growing as well as it should be. So, for example, if a woman is 5'2" and she's got a smaller baby, and I'm thinking, okay, that's probably relatively okay for her. But if a woman is perhaps 5'10" and she's got a smaller baby, maybe that placenta isn't working very well. And maybe there's a higher risk of that placenta causing a problem and perhaps the baby getting distressed in labour, or potentially there's a higher risk of stillbirth. And that's one of the big issues that we really haven't managed to tackle, the rate of stillbirth in populations around the world. There are some things we can do. We can assess people's risk early on in pregnancy. We can monitor babies' growth through the pregnancy, but actually it's still very difficult to tell exactly whether there's a risk that that baby there at 37 weeks is likely the baby's heart to stop. Now, there's lots of new technology that I can tell you about that's really exciting, which we're working on. So, I mean, currently what we rely on is monitoring the baby's heart rate, and that just tells us whether the heart rate is going up or going down and how variable it is. And there's new technology available that is doing computerised CTG, so computerised fetal heart rate monitoring, that tells us about subtle variability in the fetal heart rate. And that we know is related to the baby's oxygen level. So that's one thing that we're now implementing in clinical practice, is when women come in before they go into labour, we do what's called a computerised CTG. And that gives us an indication of what the baby's oxygen level is. And that's a very good indicator that the baby's happy inside the womb. In terms of new technology, we're working on something called near-infrared spectroscopy. So when you go into A&E and they want to measure your oxygen level, and they put a little saturation probe on your finger, and that basically sends infrared light. So it sends light through your finger. That light bounces off the blood cells in your vessels, and it tells you about the oxygen level in your hemoglobin. So it tells you about the level of oxygenated hemoglobin, the level of deoxygenated hemoglobin, and that tells you about what your oxygen saturation is. Now, there's a load of work that's been done on trying to do this. Can we shine light through the skin of the womb into the placenta and measure the oxygen level in the placenta? And more importantly, can we measure how the placenta is functioning? So measuring parts of the cells called mitochondria that are responsible for metabolism. And we're now getting some signals. We've demonstrated that we can shine light safely through the skin, through the mother's womb into the placenta, and we can get a signal back that tells us about the baby's oxygen level and also tells us about the baby's or the placental function. The placenta is the same genetic makeup as the baby. So this is really exciting because it means that we might be able to get a handle on actually how that placenta is functioning, not just a grey mass that I see on ultrasound. So it's not there yet. We've obviously got to validate it. We've got to test it out. We've got to. Patients seem to be very happy to take part. It's just a little device that sits on the outside of their skin, a bit like when you have a heart rate monitoring in pregnancy. So I think that's going to be a really important development if we can get it to work and get it to predict whose baby is okay and whose baby is not okay. And then if they're not okay, we could then perhaps deliver them earlier, or then we can start developing new treatments to help the baby and the placenta work better in the future.
Wow. Staying on technological advancements, I remember on your speech on the day that I met you, you mentioned that you can now operate a baby within the womb, a fetus, and I was mind blown. Can you just elaborate a little bit more on that?
Yeah, so this is actually, fetal interventions have been around a long, long time, many, many years. The first fetal surgeries were done back in the sort of 1990s, and even sort of giving fetuses blood transfusion into their cord was done at UCL way back in the sort of 1980s,
Wow.
1990s. So that's been around, but I think it's taken a long time for us to get to the stage where it's routine clinical practice. And that's because we need to get evidence that something is safe, first of all, and then effective, secondly, and then who should you be treating with these kind of interventions? So I was talking about the fetal surgery program that we do at UCL with Great Ormond Street and also with Leuven in Belgium. So this is really about trying to improve outcomes for babies that have spina bifida. So that's where you've got an abnormality, a defect in the vertebral column, which means that the very delicate sort of neural tissue is exposed, and it starts very early in pregnancy, right from when you don't even realize you're pregnant, around about 6 weeks, when that vertebral column doesn't close properly. And it means that soft tissue, neural tissue, nerves are exposed to the amniotic fluid and they get damaged. And there's lots of evidence to show from animal studies that if you close that defect before the baby's born, perhaps partway through pregnancy, then you improve the outcome. And so there was a big trial done in the US, published about 2011, which demonstrated that in certain specific cases, you could improve the outcome for the baby if you repaired that defect before the baby was born, about halfway through pregnancy. So between around about 20 to 24 to 26 weeks of pregnancy. So we implemented this at UCL. For the UK, we have 2 fetal surgery centres, and as I said, one with us. We also work with UZ Leuven, who helped us to implement it into the UK, and it's been funded by NHS England. So women who have a baby that's identified as having spina bifida, that's picked up about halfway through pregnancy with what's called the 20-week anomaly ultrasound. It's a scan that everybody's offered, and if we find that there's this defect that's picked up, then they get referred to us. We have a chat with them about the pros and cons, because it might not be for everybody. The baby might not be the right type of spina bifida for the repair, because there's only specific types. And it might be that they would prefer to wait until after the baby's born to have the surgical repair. And then some parents also take the very difficult decision to terminate the pregnancy. So there's 3 options. And then if people decide that it is the right thing for them, then we do an extra MRI scan to do a double check to make sure that it's the right type of spina bifida. And then we basically bring them into hospital. We put them off to sleep, and we do a cut across the bottom part of the abdomen, a little bit like an extended cesarean section scar. We lift up the womb. I'm usually scanning the baby during this whole process to check that the baby's heart rate is okay. And then we do a tiny little cut, probably about 4 centimetres through the muscle of the wall of the womb, into the amniotic fluid. We manipulate the baby's back into the right position. And then our brilliant neurosurgeons come in with their little glasses so they can see exactly what they're doing. And they basically do a gold standard 3-layer repair, exactly as they would do if the baby was born. So that exactly the same repair as they do after the baby's born. And that basically closes it drops the delicate neural tissue back into the vertebral column, and it closes over the skin. And then we close over the uterus again, we close the mum's abdomen, and then we basically recover her. And this is major surgery. And of course, it's a bit like, I say to them, it's a bit like having a cesarean section, but without taking the baby out, because they're halfway through pregnancy. So lots of painkillers, lots of antibiotics, lots of support. We keep them in for about a week after the surgery. And then we monitor them very carefully, because if you're doing this kind of surgery, there's a slightly higher chance of the mum going into labour early. So we obviously have to be quite careful about that. We give them drugs to make the womb nicely relax. And we've done quite a lot of innovations in terms of trying to improve the outcome for the mum. So, for example, we've slimmed down the size of the hole we make in the womb from being around about 6 centimetres down to about 4 centimetres. And that means that the mums are much less likely to rupture their membranes and go into labour early. But also we're working now on trying to do this using very fine, what are called fetoscopes, little telescopes. So rather than doing a big cut on the wall of the womb, we put in little fetoscopes, perhaps about the size of my pen, which go, so 2 or 3 of those, which go down into the fluid around the baby, and then we repair it a bit like laparoscopic surgery. People who might have had laparoscopic surgery for endometriosis or fertility examinations, that kind of thing. So we do that, and that means that there's a few little holes rather than one big hole, and we know that reduces the chance the mum's going into labour early. So there's quite a lot of innovation in this. We do nationally for the NHS England service, we do probably around about 15 surgeries a year. So it's not a lot, but for those babies that have it done, it does improve their outcome. They're much more likely to walk. They're less likely to need to have a little shunt, a little tube in their brain to drain off the blocked fluid that they get in their brain. So it does improve the outcome long term. But it's a big thing for mums to go through because they've got a big cutter on their abdomen, and there is this risk of preterm birth. So I think they're really brave to do it. They're fully informed, and it's very much the option for them to do that. But it's the future, and I think things, there are always various technologies that are improving. We're always trying to improve the technology. Some innovation that's coming through potentially in this particular area is to use robotic surgery down the telescope, rather than it's a person. So there's groups in the world that are developing robots to operate. Actually, what they do, it's not like having just the robot operating on you. What the robot does is it helps stabilize things. So it means that the very delicate repair that you do on the spina bifida on the baby in the womb is done much more carefully, with less wobble on your hands, because the robot is aiding the surgeon. So it's not the robot that's doing it completely. The robot is aiding the surgeon to do it better. So I think that's the future of a lot of surgery. So it also helps reduce stress and strain on the surgeon, because a lot of the time the robot's holding stuff up and all you need to do is very delicately move it, rather than having to move it back and forward like this when you are actually the person who's operating the fetoscope.
Oh, amazing stuff, mind-blowing stuff. So I guess the next question I want to ask is, what roles do you, or what role does personalized medicine play in pregnancy care currently at the moment?
Yeah, I mean, I think it's really important to look at somebody's personalized risk right the way through from before they get pregnant. So there's an awful lot that people can do before they get pregnant. And I think sort of preconception care, that time period for both the man and the woman, is really important. I mean, in some ways, it's really very personalized care, making sure that you're fit for pregnancy. So people go, men as well? I'm like, yes. So we know that if you are a man and you're thinking about having a baby, if you're overweight, your partner may be more likely to have a complicated pregnancy. So men, stop smoking, reduce your alcohol intake, stop your alcohol intake. That will improve your sperm count, very likely. Get fit. Women, get fit, stop smoking, reduce their alcohol intake, eat a diet rich in sort of a Mediterranean type diet, so lots of fruit and fresh vegetables, oily fish, that kind of thing. Take your folic acid. So taking folic acid, 4 micrograms every day over the counter, reduces the risk of the baby having spina bifida. So very important, getting fit for full pregnancy. So that's a real self-personalized thing that you can do. I think other personalised risk is, for example, with medical conditions, if you have diabetes, if you have epilepsy, if you have thyroid problems, you can now get referred to what's called the maternal medicine network. So it's clear that if you have a maternal medical condition, then if that's optimized before you get pregnant and early pregnancy, then you will have a better outcome. Things like diabetes, if you have diabetes, getting your sugar control really nicely stable will reduce the chance of the baby, of you getting diabetes, problem complications later in pregnancy, like, for example, having a really big baby. Also thyroid problems as well, optimizing, making sure your thyroid levels are good, and epilepsy, making sure you're on the right medication. So there are now ways that you can get personalized care, and you can get a referral from your GP to the Maternal Medicine Network, where people who are experts in maternal medicine, so these are obstetricians or physicians who know all about how to improve the outcome for your pregnancy. And then that also means that you can really improve outcomes, reduce the risk of things like preeclampsia, where people get high blood pressure in pregnancy, reduce the risk of preterm birth, reduce the risk of having a small baby. So I think that's why we need to get this message out, that actually there are lots of things that people can do, but it's really difficult to get that message out because, how do we do that? We have to probably put it on the side of buses. So example, in the Netherlands, in Rotterdam, they had what's called this whole public health program called Generation R, where they identified there was a massive difference in pregnancy outcome between some parts of the city that had quite underserved populations and other parts of the city that had well-served populations. And so they decided to even it up, and they did a whole program all about educating people about how to get fit, how to get personalized care for your pregnancy. And they really did it, and they advertised on buses, and they talked about diet and all of these kind of things that we can do. As an obstetrician, by the time I see somebody, if they're like 12 weeks, 3 months into pregnancy, that baby is already fully formed. I can't do much about that structures, the baby structures. Very often the size of the baby is dictated by the mum's diet. And by 20 weeks, we can see which way the baby's growing. There's not a lot that I can do in the second half of pregnancy to help people have a better outcome. There's a few things that I can do, but helping particular groups that are underserved. So particularly women who don't have English as a first language, women who are perhaps coming into this country from another country and they find it really difficult to navigate all the NHS services. You're bombarded with all this stuff and you're thinking, who should I go and see? There is now the ability to see your GP, to get some health education before you get pregnant, and actually to help. And the key thing is to get early booking, to get early care. So you can self-refer to many hospitals if you are pregnant. For example, I work at UCLH. You can go onto our website and you can fill in a self-referral form. It'll go to our lovely admin staff who will great, book you in for an appointment to see a midwife. You don't have to go and see your GP to get booked, because we now know that actually it's really important to give people that immediate access and not have to rely on going to, navigating the NHS processes.
Wow. And this is why I think it's so important to have these conversations outside of academia and just outside of like researching, because the general public, I certainly know that I wouldn't have known this unless I had gone to this event with you. But yeah, so it's essential to have these conversations, because I know now there will be a handful of people that are like, oh my God, I can actually go to my GP and request these things, So with that said, how do you feel genetic screening is evolving at the moment, and what should expecting parents know?
So I think there's a lot of developments in genetic screening. It's a very exciting time because of the developments that have happened in the whole sort of genetics. So particularly in pregnancy, we have the whole area of what's called non-invasive prenatal testing. So it's very clear that there is evidence of genetic material from the baby's placenta swimming around in your blood when you're pregnant, which is pretty amazing. It's just little breakdown products from the placenta that's released into your blood. So, for example, you can do a test from the mum's blood to work out if the baby she's carrying is a boy. And that's because you will pick up, if you would do a test for the Y chromosome, which is the chromosome that's carried by male children, you will find evidence for that Y chromosome in your blood. And about 6 hours after you have the baby, that level will go completely down to zero. You won't be able to detect it. So that tells us, it's a really amazing signature that tells us about the baby's genetics potentially, and also probably a little bit about the baby's well-being as well. So these are now tests that are your audience will be familiar with some of them. You go along and get a blood test, and that is being used to screen for things like Down syndrome. So that's where you have an extra copy of chromosome number 21. But yes, okay, Down syndrome is fine. We can screen for that. But actually, can we make a diagnosis? And so increasingly, we're able to make a diagnosis, for example, for single gene disorders. So, for example, things like brittle bone disease. We potentially can make a diagnosis if the mum doesn't have it, but the fetus has it, the baby has it, and the baby's genetics is the same as the placenta. You'll be able to pick out that particular gene for brittle bone disease in the mum's blood. So we can now make a diagnosis rather than putting a needle into the amniotic fluid, taking a sample of the baby's skin cells in the amniotic fluid and making the diagnosis. We can now do this from the mum's blood. And ideally, we'd like to do that for lots and lots of single gene disorders, sickle cell, thalassemia, all of those things, which are very prevalent in many populations. So black populations, Mediterranean populations, Southeast Asian, etc. It's quite difficult because there are a number of genes for these particular, not so much for sickle cell, but for thalassemia. And people are working really hard on trying to make it diagnostic, because diagnostic means it's 100% correct.
Wow.
So yeah, and that's quite a challenge if you're going to completely rely on taking the mum's blood and making a diagnosis. So that's the challenge. But I'm pretty confident in the next 5 to 10 years we will be able to make a diagnosis for things like sickle cell and thalassemia from the mum's blood. So that's really exciting. I think non-invasive prenatal testing. The other area as well is what's called whole exome sequencing. So we can now genetically sequence our DNA. So that's the strings of genetic material in our nucleus, in our cells.
What?
And exactly. And it's the cost is coming right down. So, it used to be millions of pounds to do this. It's now probably 2,000, 4,000, something like that. The cost is really coming down. Of course, that gives you huge amounts of data. How do you interpret that data? That's the challenge. Well, if we now see a baby that has, let's say, a heart defect, we can see on scan that the baby's got some kind of heart defect. Rather than just looking for chromosomes, which is how many strings of genetic material do you have, we can now hone in on particular genetic sequences and say, right, we know these particular genetic sequences are associated with cardiac disorders. Mm-hmm. Can we test for them? But more importantly, can we compare the baby's genetics with a normal genetic analysis and see whether there are specific abnormal genes associated which are probably related to the heart defect. It does mean to say that women would have to have an amniocentesis. They would need to have a little needle put into the fluid around the baby under ultrasound guidance to take a sample of the baby's genetic material. And that carries a risk of about 0.5% to 1% of baby loss. But, if you find a defect in the baby's heart, for example, it's really useful to be able to identify is there an underlying genetic disorder, because that might influence the baby's outcome. What surgery it might need, and the baby's long-term prognosis. So this is really coming in. We now have NHS England now has a directory of genetic tests that we can do if we find a baby with a structural abnormality, like spina bifida, like a heart defect, and we can now send off the fluid and get whole exome sequencing. Blown your mind away with that. In the future, we will have whole genome sequencing. So that's not just analysing parts of the genetic sequence, it's analysing the whole of the genetic sequence. And there's now a study in the NHS, which is being run by Genomics England, called Generations. And that's a research study that is basically offering parents the opportunity to sequence their child's genetic material after birth. So what it means is that mums and dads who agree At the time of the baby's birth, we take a sample of the cord blood, which is taken from the placenta, so no risk at all. We send it off to the lab and they do the whole genome sequence. And what they want to find out is whether the particular baby has a novel single gene disorder, a novel mutation. Maybe it's some kind of enzyme problem, which, if it was identified early and treated really early, might improve the outcome. Because there are some cases being reported now where babies have been born, look completely normal, and then have big problems in the neonatal unit. And they now have access to rapid genetic sequencing where they can run the whole gene sequence, not just a panel and go, which particular gene is it? They'll run the whole gene sequence and say, that looks a bit odd. That tells us they've got this disease. And then they can instigate some treatment really, really early. So if anybody's listening, Generation Study is happening right now. And it is probably going to transform what we do, because it'll pick up all these genetic disorders, not every single one, but a lot of them that are going to make a difference to the outcome. Now, of course, what it does is it gives you huge amounts of information. How do we interpret that information? We're going to need an awful lot more genetic counsellors to help us interpret. There will be variants of unknown significance. So is this a pathogenic variant? Is it a non-pathogenic? Is it a concerning variant with pathology, with disease? Or is it a normal variant, which is just a normal, variation in the population? So lots of information which will need to be interpreted. So, with caution, but yeah, very exciting times, as I said at the beginning.
Wow. Again, mind blown. So with everything you've just said, what recent advancements in fetal medicine do you find most promising currently?
Yeah, I mean, I think one of the areas is going to be whether we can assess and improve outcomes for babies where we've got a diagnosis. So things like, can we treat genetic conditions? Can we treat fetal conditions before birth? And there's quite a lot happening on this. I mean, there's a recent paper just out there, which just a case report, which was a condition in a baby called spinal muscular atrophy. So this was a baby that had it diagnosed in the womb. So spinal muscular atrophy is where you have an abnormality of a gene that's responsible for your signaling to your muscles. And effectively, it means that over time after birth, the baby becomes weaker and weaker and weaker. And of course, with this new ability to make the diagnosis in the womb, it opens up a world of being able to say, okay, we can treat that baby before birth. So what they did was they used a drug which crosses the placenta called risdiplam, and it's a small molecule drug, and it basically alters the way that this abnormal SMN1 gene functions. So it increased the ability of that abnormal gene to produce normal functioning protein. Basically, at the age of 2 in this child, there was no evidence of spinal muscular atrophy. So essentially what they found was they just used a protein. It was a medicine which they gave to the mum, crossed over the placenta, which actually improved the outcome for the baby. So this is really exciting because, obviously it's a risky thing to do. The mum had to sign up to say, yes, I wanted to take part. I was I was prepared to take whatever risks they thought that there might be. But what it meant was that the baby essentially has no features of this genetic condition at 2 years of age. So, that's just one example of what is really going to be happening treating genetic conditions before birth. There's another trial that I'm involved with, which is a trial of genetic skin disease. So we know that we can diagnose some rare babies that have a skin disease before birth. It's an X-linked, so it's inherited by boy babies. And it affects their skin, their sweat pores and their teeth. And it means that they don't have any sweat pores and they get really, really hot. And there was a company that developed a treatment for this condition, which basically was a protein, but they found it didn't really work after birth because, of course, babies after birth have all their teeth and they have all their sweat pores. But before birth, those parts of the baby are developing. So we've been doing a trial with a company, putting in the protein into the amniotic fluid 3 times during pregnancy to basically allow the teeth and the sweat glands to develop. And it appears to be working. So most important thing is this safe and is it effective? So I think that's another area. If we're going to be doing genetic treatment before birth, we need to absolutely make sure that these treatments are safe and effective, because actually that's what mums and dads want to know. How is it going to affect my baby? Is it going to make my baby, am I going to go into labour early? You'd be surprised how difficult it is to do trials in pregnancy. It's really, really challenging. Of course, parents want it. If you make a diagnosis of a condition in a baby before birth, and the mums and dad often will say, well, is there anything I can do? And they're desperate for treatment. So I think there are a number of treatments on the horizon. Of course, the difficulty is you've got to make sure that those trials are safe, done really carefully. And so some recent work that we've been doing is how can we make trials of genetic therapy more safe in pregnancy. So we've come up with a way of doing that, and it's basically developing some new terminology, which means that you can collect up all the information about how the mum is and how the baby is by using this sort of new vocabulary, really. You'd think that this would have been developed years and years ago. Assessing safety in trials of cancer drugs has been around for at least 40 years, but it was only probably about 5 or 6 years ago that we came up with this new vocabulary. What it means is you can assess safety in the mum and in the baby, and you can say, yes, this is safe or this is not safe. So it might seem a very simple thing to do, but so important to get it out there and to get people who are doing these clinical trials to assess safety and to publish their data on the safety as well.
Wow. You've slightly touched upon technology and how it's assisting in prenatal care. How do you see AI and machine learning shaping the future of obstetrics in the future?
Yeah, I mean, I think AI machine learning is going to affect all medicine, really. Oh, it's affecting all of our lives. You put into Google a search and it comes back with the AI, and you think, oh, that's really good, isn't it? I think there are 2 ways. There's a really nice recent study published in the New England Journal of Medicine, which is a quite a famous medical journal, where they basically some sonographers worked on how they can use machine learning to improve just the basic ultrasound that you do. So your 20-week scan, if you use AI to tell you, to show you how to improve the images that you get, and to speed up measurement of the actual images that you get. And what they found, very simple, it took a lot of computing power, but very simple, they found that it could speed up doing the scan, speed up interpreting the scan, but also, most importantly, probably reduce the amount of time that the sonographer has to move around the woman's belly to get the right images. So I think that's going to be, that's a really good thing to do. I can see that coming in quite quickly. I think the other area is also CTGs. So that's where you have the heart rate monitoring in before labour and during labour. And what you need for machine learning is to have really big data sets to compare, for which you have a known outcome. And then you say, right, we know that. And then I've got a new data set here. And you say, what does that big data set tell me about this new measurement that I've got? And so in Oxford, at the Oxford Big Data Institute, they've got lots and lots of data about fetal heart rates in labour and their outcomes. And so what they're doing is they're applying machine learning to interpreting the fetal heart rate, the CTGs, to basically be able to say, this CTG is normal, baby's happy, let's carry on with the labour, or this CTG is a problem, this baby's got low oxygen level, we need to get them delivered. So I think you can see a bit of a theme here. There's a lot of technology being thrown at how can we better monitor the fetus in the womb, in that little black box we were talking about early. How can we get more information about that baby, given the new tools that are coming through?
Wow. I want to talk a little bit about stem cell research. So, how could genetics and stem cell research shape the future of neonatal health?
Well, yeah, I mean, of course, stem cells are big in neonatal health, aren't they? Because people can now do bone marrow transplants for conditions, for leukemia conditions, and they're also using stem cells in the neonate to treat things like immune deficiencies, that kind of things in the neonate. So we've been doing quite a lot of work looking at, can we use stem cells to treat the baby before birth? So again, coming up with this idea of, you have a diagnosis of a baby with an abnormality, and what can you do to treat it? Can you actually treat it? And actually, quite a few, a few years ago, it was back in the sort of late 1990s, 2000s, there was a team in Sweden that did the first in utero stem cell transplantation for brittle bone disease. So what they did was, it was a couple that had a child, a fetus diagnosed with brittle bone disease. So this was where the limbs were really, really narrow, short, and broken. And you could see on scan that they were fractured. And it was very clear they had a molecular diagnosis, that they had an amniocentesis confirming that the baby had this mutation in the collagen. So it's a protein important for bone development. And so what they did is they took stem cells and they infused them into the umbilical vein. So a bit like doing a fetal blood transfusion, they put it into the cord of the baby, and those stem cells honed to the fractures in the bone in this particular girl. And when she was born, she grew better than other children that had similar genetic abnormalities. She had fewer fractures and that kind of thing. So, she's now in her teens, and that result was the basis for a big clinical trial that we conducted with the Karolinska in Sweden, and also with the team in Germany and the Netherlands, called Boost Before. So it was a trial of stem cell transplantation for brittle bone disease. And it's great, of course. One of the issues was, we started the trial, the first patient was infused March 2020. What were we doing in March 2020? We were all going into lockdown, weren't we? So that was not an auspicious date to start a first in human clinical trial. But anyway, we did. We completed the trial. We're just finishing analysing the data. Most important things to say is that actually the safety of that study was really good. So we were looking at adverse events, safety signals, and we had no serious adverse events and very few minor adverse events. That was great. And the other thing to say is that parents wanted to take part. So we talked to parents about if they had a baby with brittle bone disease, what did they think about taking part in a clinical trial of stem cell transplantation before birth? And overwhelmingly, it was positive. Not everybody would want to take part in a trial. Not everybody that we spoke to had a baby with a diagnosis, wanted to take part, but we managed to complete the trial. And the data looks positive. We're still finishing analysing it, but it looks positive. And so I think there will be more stem cell transplantation trials coming through. And the way forward is really to say, okay, patients, what do you think about this? And I've always found patients are very sensible people. You talk to them about what do they want, and they usually say, well, I want to know, what's this risk? And very often you come up with things that you wouldn't necessarily think about. So with the OI patients, one of the big things they wanted to know was, how big is my child going to grow? Because if you have brittle bone disease and you have really many fractures, very often the individuals are very short, and that they really don't want to be short. They want to be taller. So they wanted to know, how big are they going to grow? So talking to patients is so important when you're developing novel technologies like this.
Wow. I'm just mind blown by all of this. If you are a young couple who are thinking about maybe starting a family, what are the things that you think they should be considering, when thinking about how the fetus develops, how to have a healthy fetus, how to avoid maybe having a fetus which develops with complications? Do you have any advice, or should there be anything that they should consider?
So I think getting fit before you get pregnant is a really important message. So, this whole thing about if you move house, you plan it 6 months in advance, don't we? If you go on holiday, I bet you've booked your holiday, haven't you? You've booked your
I
holiday.
have.
How long ago did you book your holiday?
Last year.
You planned it last year. Okay. I won't ask you whether you're thinking about having a baby, but most people, when you talk to them, very few people plan their pregnancies, and it's such an important message. I'm part of a team called the Preconception Partnership, which is a collaboration between UCL and Southampton universities. And we want to get the message out there that planning for pregnancy is so important, because actually, if you have a planned pregnancy, you're more likely to have a better outcome. All it means, it might seem like a big thing, it just means I'm thinking about it. So you might cut down on your alcohol, you might get fit, you take your folic acid, you eat a better diet. And actually, I think you can inform yourself as well. So there's lots of really good websites out there. So Tommy's Charity, for example, I'm very privileged to be part of the Tommy's National Centre for Preterm Birth Research. I'm the deputy director, and they've got really useful information about what couples should do. They've got a really nice little thing about you can go on and tick off what you're currently doing and then what you should be doing. And I think it's for both men and women. I think the other thing is that we know that subfertility, fertility problems, conception problems is also quite a problem. And so if people are sexually active and having regular sex for at least a year, and they're finding they're having difficulties, don't sit at home thinking, oh, it's fine. Go and get referral to your GP and go and get seen, because we know that it can be a huge problem for couples. Very often, it's not always the woman. It's about 1/3 of cases, it's a male fertility problem, which can be very, very treatable. Like you might have a reduced sperm count, for example, and simple things like lifestyle changes, that kind of thing might be something that works. So I think that's a really important message. There's lots of innovation that's being developed in things like prevention of recurrent miscarriage. So some really nice data showing that if you've had 2 or more miscarriages, that taking progesterone, vaginal progesterone in early pregnancy, when you find out you're first pregnant, can improve the outcome and prevent recurrent miscarriage. Lots of great research coming out of the Tommy's Miscarriage Centre. So I think all the evidence around miscarriage, and obviously we're doing a lot of work on the Preterm Birth Research Centre, is going to make a difference. But it's hard, these complications in pregnancy are common, but even so, most women who have a complicated pregnancy generally have a good outcome.
Wow. Dr. Anna David, I want to say thank you so much for coming along and giving us so much invaluable information. I have learned so much, there's no doubt the listeners will, and we're all going to go off and research all of this stuff now. I will place all of the links for your social media and the Tommy's Charity. Is a charity, right? If I'm not mistaken.
It is. Yeah, it's a charity. Yeah. Also, plug for Shine, the Spina Bifida charity, and SBH Scotland for any listeners out there who might be affected by spina bifida. They're a really great charity who can support people who are making decisions about whether to go ahead with fetal surgery or not.
I'll make sure to have the link for their contacts on the comment section just here. And thank you so much for coming. It's been great to have you on the show.
A pleasure, Celia, and great. Thank you so much for inviting me.
You're most welcome.